Major support for these broadcasts is provided by the CUNY TV Foundation, New York Community Bank, Chase Commercial Term Lending, Chelsea Lighting, Capital One Bank, Genova Burns, Giantomasi and Webster, Kilroy Architectural Windows, New York's Window Company, the Witkoff Group, Greenberg Traurig, M&T Bank, Perfect Building Maintenance. Additional support is provided by Ackman Ziff Real Estate Group, Bank of America Merrill Lynch, Briarwood Organization, C.B. Richard Ellis, Colliers International New York, Cushman & Wakefield, Dime Savings Bank of Williamsburg, Douglaston Development, Levine Builders, DDG, Friedman LLP, Accountants and Advisors, Flushing Bank, Herrick Feinstein LLP, Investors Bank, James D. Kuhn Real Estate Center at Syracuse University, James Orphanides, Centurion Holdings, John Katsimatidis, Red Apple Group, Corman Communities, a.k.a. Hotels, Madison Realty Capital, Margolin Weiner and Evans, LLP, Certified Public Accountants and Business Advisors, Massey Knackle Realty Services, New Banks, Meridian Capital Group, Newmark Grubb Knight Frank, Popular Community Bank, Sterling & Sterling, SJP Properties, Stonehenge Partners, and These Friends.
This is a continuation of our discussion on healthcare, Obamacare, hospitals, what's happening in medicine and everything. And my guests, they include Michael Dowling of the North Shore-LIJ, Barry Rabner of the Princeton Healthcare Systems, and Dr. Steve Safyer of the Montefiore Medical Center CEO. You cut yourself. Now, you have to realize, Steve and I and Barry don't have that problem because we don't know how to utilize tools. It wasn't in our heritage, you know.
Well, it's very obvious I don't either, because I cut myself. But the point I was trying to make is that the emergency department, in many cases, becomes the primary care place. Because if something happens to you after hours or on a weekend, like it did to me, the only place I could go in my neighborhood was to the emergency room to get seen. So the emergency rooms, while they get criticized an awful lot, they do serve that backup function. What we have to be doing over time is changing the delivery system, creating other distribution locations, so you don't necessarily always have to go to the emergency room if your physician is not available.
So here's my question, getting back to the doc in the box. Do you believe that the doc in the box really helps healthcare in 2013 in the future? Or is it, as we were saying partially during the break, that I do remember in the 70s, there were things known as Medicaid mills, which were totally figuring out the system of how you could do nothing and get paid for reimbursement.
Yeah, I don't think they're that, but the model is to get you into the pharmacy, if it's a CVS or a Walgreens. The money is made on the food they sell and the other things, the notions and so forth.
But that's within the facility. That's in the CVS.
Let me answer your question. It's not necessarily a solution because the problem is fragmented care. That's what makes patients unhappy. That's what provides poor and expensive care. You need access and the ability to navigate a system. And when they're on their own and they're out there and they're being promoted by others, I don't think they work well with the delivery system, and their information systems don't talk to the hospitals.
But what I said before, we've increased from like 700 at one time in the retail to 1,300 to 2,000, 2,800. I mean, they're proliferating, they're opening up. I mean, I know that in New York City, they're in most of the Duane region.
Pharmacies are not making money on the pharmaceuticals, and they're not making money on the doc and the box.
So they're making money in the rent?
The other stuff they're selling.
So they go in there and then they'll get a yogurt and some lunch and something else.
Beer.
That's what you
Cigarettes.
Okay. Beer and cigarettes. That helps your business.
No.
No,
It doesn't.
But
We'll be doing a better,
That's another point. We'll come back to that.
we'll be doing a better job as providers when we're more successful in coordinating all of the care that our patients are receiving and making sure they get the care at the right level clinically and the right level in terms of costs. And that results in different solutions in different locations, but they need to be coordinated. And that, I think, is Steve's point. That's what's missing.
you brought up an interesting statistic before about how many hospitals there were once in New Jersey and how many there are today. I'd like to bring up that point that if I remember 25 years ago, there were a lot of hospitals in New York City before the change of the report that came out a number of years ago. I still remember when we had Cabrini Hospital and we had St. Vincent's Hospital. We had a number of hospitals in Brooklyn. We had a number more in the Bronx.
We had 15 hospitals closed in New York State since 2008.
What do you see in the next 5 years?
I see a choice for us. Either we continue to close hospitals without infrastructure and program to replace them, or we do what the Medicaid redesign team recommended, which Michael was co-chair of. New York State did an extraordinary thing 2 years ago. It said we're going to cap Medicaid spending and redesign the care so that we can lower the expense. We did the first, now we need to do the second. And what we need to do is take facilities that are capital starved, that are on the verge of bankruptcy, don't have cash flow, can't invest in themselves, and can't provide state-of-the-art care, and bring them into regional systems that allow that institution to be repurposed to do things like we've been discussing. An emergency room without a hospital bed, or a procedure area, or primary care, or subspecialty care, and have them part of systems that are integrated and coordinated and are forward-thinking.
You have 15 hospitals today.
Yeah.
But how many have you merged in the last 5 years?
Oh, in the last 5 years, about 7.
That's a large number.
But these have to be completely integrated. These are not things just kind of pretend, which is, I think, what Steve is talking about. So you'll have more consolidation, and I think you should. I think it's the right thing to do. And one of the things is the regulatory operations, both at the state and the federal level, all of the regulators from all the different agencies who are all over this all of the time, they have to understand the benefits of this kind of integration, because you can't at the one hand talk about care coordination, how you manage people's care, and then require that everybody be disparate and different. You've got to allow this integration to occur. And the other thing that we haven't spoken about, but I would just think is very, very important here, is that what people don't understand, because the emphasis is always on the facilities and hospitals, about we have these bad numbers on healthcare, for example, they will say, especially if they compare us internationally, that more ill health in most cases is due to social environment, lifestyle, behavior. So there is a whole.
Are we getting back to my discussion of beer and cigarettes?
Yes, that was what. It's the whole social environment that drives an awful lot of the cost of healthcare. I mean, the obesity epidemic, right? Issues around depression resulting from the obesity and cardiac resulting from obesity, just using obesity as one. These are all things that occur out there. We try to deal in part with it, but it requires a lot of other agencies, social agencies, community-based agencies, churches, individual responsibility. All of that has to be put into the mix if we're serious about changing healthcare and over time reducing the cost.
Now, you bring up obesity, and I read your website, and I read your websites. I don't remember when people were doing bariatric surgery, and that's a big item. I mean, I think certain of your competitors or friends are open 7 days a week to do surgery on Saturday and Sunday.
I think the need for bariatric surgery, though important for the individual, some individuals picked in a particular context, is a symptom of a failed social structure. So if you have soda that's available as it is, cheap, in large quantities, with tons of sugar in it, and people are drinking that all day, not satiated, no inhibition on doing it. It's equivalent to cigarettes. So we have an obesity epidemic in this country, which is driving.
Do you believe, is there being an abuse on the amount of bariatric surgery today?
Not
because
no, not in. I mean,
well,
there's an abuse of everything, but not.
no. I mean, you know, I
institutions.
read that you're in this business. You're in this business. Okay.
I remember also that the technological development, the technological advancement allows you to do these things. You couldn't do a lot. The reason you didn't see this before, in part, you didn't have, when you were young, an obesity epidemic in the United States. It basically began in the 1980s. Now, the cause of it went back much earlier than that, but the results showed up in 1980, and the science was not around.
Right, but isn't it also the procedures that we were talking about, different hospital procedures? We didn't have minimally invasive surgery. We didn't have the lap bands. We didn't have this type of procedure over there.
You have to be highly skilled to do bariatric surgery in the way that all of us do it. I think all of us, in a heartbeat, would be happy if we didn't have, in the Bronx, 3/4 of the Bronx is obese. That's affecting children right up to elderly with.
Are we having obese?
When we designed our new hospital, we had to design it so that 1/3 of the furniture we purchased was for people who were overweight. And it's probably inadequate. You know, I think Michael's point is really important. You know, we don't do enough to deal with the socioeconomic issues that are impacting health a lot more than a lot of the clinical care that we provide, and bariatric surgery is a good example. I wish I knew who said this, and maybe someone here knows, but they would say your zip code means more than your genetic code when it comes to
Geography is
how you
destiny.
doing.
Yeah, you know.
And the important point here is that if you listen to most of the talking heads out there and the media, you know, in the American healthcare system, the hospitals and the docs, people who work in all of these places, cause all these problems. Now, we have a responsibility to do a much better job than we're doing, and that's what we're trying to do. But these problems are not caused by the healthcare system. They're caused by social environment and lifestyle and behavior. We have to acknowledge this. And we should be doing better, but you can't on the one hand lay blame for that on this.
The biggest determinants of health are employment, education, housing, and opportunity. And you know, I think in this country we think everything can be solved in the healthcare system. We will always need a healthcare system, but we need a comprehensive approach to these public health issues.
I did a program in Florida yesterday with the head of the Scottish health system, not a doctor, it's Derek Feely. Now, Scotland is a very different country. They have a different organization, and I'm not suggesting that's right for the United States. But in his role as the top health official, he also has responsibility for all of those other social programs, not just the medical. We apply a medical response to a social issue when a medical response is necessary, but so are the other pieces. If you don't put the two pieces together, or the multiplicity of pieces together, you're never going to get to where people want to get to. You can cut doctors' salaries, and you can cut their payment, you can cut hospitals, you can reduce the number of hospitals, et cetera, et cetera. You're not going to necessarily deal with that other side of it. And that's something that, it's not a cop-out. It's not saying, as some people would say, well, you're trying to just move yourself away from the sense of responsibility. I'm not doing that. I'm saying that it's ridiculous to be suggesting that if you build fewer hospitals, that people will be less obese. It's just going to happen.
You know, you bring up Florida, and Florida relates to a couple of things. I know people who are in Florida, which I will never be in, who never want to have their medical treatment in Florida. They don't trust the hospitals, they don't trust the doctors, and they say, I must come to the Mecca of the world. Now, you have a similar problem because people, even though New Jersey, Princeton's a great medical, you have great hospitals, you have medical schools over there, they want to come to New York City. I don't know why they want to go to Cleveland, but they want to go to Cleveland, they want to go to Philadelphia, or they want to go to Houston. Why do they always come to the Mecca of the world? Is it we have the best doctors, we have the best facilities, and
well, you know, I think people travel for various reasons. If I lived in Florida and I needed care, I'd probably get on the airplane. But I do believe that New York deserves the reputation it has. We educate more doctors than anywhere else in the country. We do more NIH research than anywhere else in the country. We have, this is a medical town, and we should be proud of that. And people come here because there is extraordinary care, and we're on the cutting edge of new technology, new techniques, research, et cetera, et cetera. But, you know, I think some of the traveling has to do with just consumption and how people behave
Perception,
in a marketplace.
But also with regard to the Florida issue, remember a lot of the people in Florida used to live here. They move down there, they're comfortable with being here, and they come home.
Correct.
When they have a medical problem, and we get them, and Steve gets them, etc.
Yeah,
It's a suburb.
enough about the quality of care in Florida comment, but I think one of the problems is people don't have enough objective information to judge the quality of care, to make a decision about where to go, so they tend to go where there's a powerful brand, believing that there's something special there, and there often is, but it's because they don't have objective information to decide.
Barry, one of your big supporters who introduced me to you, his wife needed surgery recently, and the comment was, it was, I believe it was a knee replacement, and everybody said to him, Jimmy, how could you be sending it? And Nora said, I trust my hospital. I trust these people, and I'm going to be comfortable over here. You know, everybody said, go to HSS, go LIJ orthopedic, which we'll get into in a second. But, you know, how do you handle that?
Well, in that case, she trusts because she has the data to make a decision about where to go. Yeah, part of it also is people, like in our hospital, we don't aspire to be able to do everything for everyone. We think that
transplant will send to my friends.
We think we can do a good job with probably 85% of what people need. So from a business standpoint, we can do fine, and we can deliver terrific care in the areas that we work. For the other 15% of what people need, you know, our job is to recognize what our limitations are and to guide our patients to the best providers.
And that's why you have relationships in Pennsylvania with the Children's Hospital over there.
Exactly. That's probably the best example to use.
Now, here is a situation. I work out in the gym because I don't watch television too often, and all I see is this Cancer Centers of America advertising constantly. I mean, I have no idea, but Middle America sees these ads with a Middle America person. You know, I was told I have stage 4 cancer and I'm going to die, and now pancreatic cancer. I'm alive because I go to Cancer Center in Philadelphia or Cancer Center in Arizona. I don't know who these institutions, I assume it's a private enterprise, it's not a nonprofit. I mean, Cancer Centers America and advertising is my discussion. If I pick up the New York Times magazine on a Sunday, I see you advertising, I see you advertising, I see Corwin advertising, I see all of your competitors. What is this? I remember when it was criminal for people in the institution to advertise.
Well, I
mean,
advertise because
in Limerick, did they advertise?
huh?
In Ireland, they didn't advertise? You know?
Well, I don't think advertising is a bad thing. I think you're promoting what it is you do.
But who are we promoting it for? Are we promoting it, as you said to me before, for my docs? Am I promoting it for the community? Or am I promoting it to take away business from him and him?
First of all, it's a small percentage of our expenditures.
Very small.
And so it's overblown. But we are speaking to different audiences. I could speak for Montefiore. Recruiting, you know, highly specialized physicians from across the country. You want to project a certain image. Fundraising, which is important to all of us. You want to project a brand. And particular to us, we have used in the Bronx creative advertising that's local, that you don't read, you don't see, that's targeted to communities that are indigenous to the Bronx. And we use that as almost like public information, and we communicate with our communities.
How important is it to be the official hospital of the New York Knicks or the the Brooklyn Nets or the Red Bull soccer team. I mean, and it's an expensive proposition. I mean, you may say the advertising and branding, but it's expensive because if I remember when I was on the board of the Hospital for Joint Disease, we had to have an ambulance over at the hospital, at the stadium, and we had to have 3 doctors to be there. And the worst situation is when somebody got ill, they went to HSS, even though we were the official hospital for the institution.
Well, I think it's people try to get name recognition. They get a brand. I mean, if you see the icon of the emblem or the signage of a hospital behind the next bench, people, hopefully the idea being people remember this. Not everybody will follow that. Some people ignore it completely. But it's like why anybody advertises for anything. I mean, people spend billions, companies spend billions. Many companies spend more money advertising
what
than
you
doing
said
production.
about the Knicks and the bench is very important. I think it's a subliminal, like in the movies.
When they're winning.
Right.
When they're winning.
When they're winning. I mean, now the Knicks, hey, they must be a really good team.
There's an interesting side to your question, though, because people often want hospitals to function more like businesses. And then if hospitals do anything that looks like they're competing, it's assumed to be a bad thing. But I believe, and I don't know if my colleagues agree, but I think competition makes us better. And I don't see what's wrong with that. It can be abused, and hopefully we use enough good judgment in that regard. But I think competition is a good thing. And if we're competing by advertising, I don't see anything, there's nothing given in that that's wrong to me.
I agree with you.
But here's the question. Do we have too many, and in the same manner that you said that we closed 15 hospitals, do we have too many institutions who are centers of excellence in orthopedics or centers of excellence in cancer care and centers of excellence in XYZ? Or should that be a consolidated subject?
We serve 8 or 9 million people, more if we include Princeton, New Jersey. This is huge neck of the country.
And remember, one other thing that I don't think that people out there understand is while we compete, we also work together a lot. I mean, patients move back and forth between us, and we refer patients to one another when something occurs that we may not have the expertise that somebody else does. That happens on an ongoing basis. Like Steve and I, Montefiore and Shore-LIJ, we work together. We learn from each other. We share information. We don't
have 15 programs that we're doing that
together.
Are extensive, important, and coordinated.
And that's all positive. And so I think competition is good. If somebody is doing something better than you and you're in the same space, you want to find out why they're doing it better. Right. And so it makes you better. And then in turn it makes them better. That I think overall benefits the community in general.
And specialization is good for our patients because the more focus and the greater the volume of activity in one area, I think the better the results. Now, whether the branding that goes on top of that, this is a center of excellence and that's an even more excellent center, that's another issue. But specialization, I think, often results in better care for our patients.
Steve brought up part of his advertising is utilized for fundraising. You were quoted in a paper, especially since you had a 7-year project to build this hospital, that a good portion of your time was spent in site visits of people to the facility and fundraising. How important is fundraising in running a major healthcare system today and a community facility?
For our project, we actually took us 9 years from the time we came up with the idea till we opened, and we would not have built a new facility without a capital campaign and without the community support. We raised, which for an organization our size, I think is significant, about $175 million.
And you originally planned to raise $40 million, right?
That's about right. We would never have undertaken the project without that support. So it would have been critical to our survival.
I got to get a hospital in his neighborhood.
Don't worry, I'm not surprised. You'll be out there. You'll
actually he's got to have one in your neighborhood. You know he's coming.
You know
you know he's coming. No, I'll give you an example. We opened a brand new children's hospital 11 years ago. Okay, first in the Bronx, serving 500,000 children. very needed entity, and we raised $100 million. Without that $100 million from very generous supporters, it would have been impossible to do that. It's now one of the top-ranked children's hospitals in the country.
Similar. I mean, I spend probably a night or 2 nights a week meeting with people who, these are people who have done well, are interested in giving back.
And they also want an insurance policy.
Well, they want to have a good relationship with the health system, but they also are going to give money to somebody. So why not to providing health care to people?
Tax law. What effect is the change of potential tax law in itemization, deductibility for
It would hurt us all. It hurt us all. We're all opposed to it.
I think it would be somewhat of a ridiculous change to make. Because it's not just us. I mean, think of
everything. It's the arts. It's everything.
It's everything.
It's, you know, it's.
That would be a foolish thing to do. I mean, in many ways, the situation in the United States is relatively unique in the tax treatment of giving and the extent to which people give. It's a unique quality to the United States character. I don't think this is. They may make adjustments in it, they may change it, they may put some caps in it, etc. But to eliminate it altogether,
the $100 million I spoke about for the Children's Hospital would have had to been $130 million. So basically everything would be discounted by 30%.
You know, you brought up another reason for advertising and branding. It was getting, you know, it's like you're in the Bronx, so I can talk about the Yankees. You know, bringing those superstars. How hard is it to bring the superstar to Princeton or to North Shore-LIJ and to Montefiore? I mean, and you have brought some superstars. I mean, Rabner, you know, from your cancer center, I know that, you know, some great guys. How hard is it to recruit today? Top people.
You mean physicians?
Yeah.
Very competitive.
Oh, it's very competitive. I've been very, very, very fortunate. I mean, I do not have an issue.
Do we have A-Rod contracts? I mean,
yeah, you have contracts with you compete for people, and in almost every one of the major leaders that I'm competing for at the moment in the clinical area, the competitors are, you know, the other hospitals in the city here, Hopkins, Mayo, Cleveland. They're all in the mix. And, you know, yes, we get a good share of those, much more so than ever. 10 years ago, that was not even possible. Today, it's pretty standard.
You have to pay market salaries.
And you pay market.
And this is New York.
Yeah.
I think what's changed now compared to 10 or 15 years ago when there was a lot of activity in employing physicians was there's a lot more, in their contracts, there's a lot more having to do with their performance and the quality of their care and the results.
Since the healthcare business is a business, that's what you have to do. And I'm really happy that all three of you have given me and my audience some insight on healthcare in 2013, the future and the states and what's happening. And I'd like to thank Michael Dowling, Barry Rabner, and Steve Safyer, and I'll see everyone next week.